All right, let's dive right into this explainer on reproductive health. With sexually transmitted infections at an all-time global high, today we are exploring some of the most common pathogens, exactly how they operate within the body, and most importantly, how modern medicine intervenes to protect both adults and newborns. It is a truly incredible intersection of microbiology and maternal fetal care. We've got a lot of ground to cover today. We'll be looking at viral STIs like HSV and HPV, bacterial and parasitic infections, the 4 distinct stages of syphilis, hepatitis B's effect on the liver, exactly how HIV attacks the body, and finally, how we manage and treat HIV. Okay, part 1, viral STIs, HSV and HPV. So the crucial thing to understand right off the bat is the difference between HSV type 1 and type 2. Traditionally, you'd see HSV1 causing oral lesions, spreading through saliva, right? While HSV2 typically cause genital lesions and spread sexually. But because of varying sexual practices, both types can actually spread to opposite areas through direct contact. Now, what makes HSV particularly tricky is something called asymptomatic viral shedding. Basically, this means the virus can be transmitted even when there are absolutely no visible lesions present. To really lock this clinical presentation into your memory, just use the acronym HSV. H stands for herpes. Those are the red, fluid-filled, really painful sores that tend to cluster together. S is for sensation. Patients will often report this fiery, tingling, or burning warning sign right before an outbreak happens. And V is for viral symptoms. Think fever, body aches, and swollen lymph nodes. Now, in maternity care, this is absolutely vital. If a pregnant patient has an active genital HSV outbreak during labor, a C-section is usually highly recommended. We really have to protect the baby from contracting neonatal herpes, because that can cause severe neurological damage. Moving on to HPV, remember the WART acronym. W is for warty growths that kind of resemble the head of a cauliflower. A is for asymptomatic carriers, folks who are entirely unaware they even have an infection. R is for rough texture. And T is for tender to the touch, since they can sometimes bleed with sexual activity. While we know certain strains of HPV can lead to cervical cancer, the strains causing these genital warts can actually complicate pregnancy too. It's rare, but if it's passed to a newborn during a vaginal delivery, it can cause respiratory papillomatosis. That's a condition where the newborn develops warts in their throat that can dangerously block their airway. Literally a life-threatening situation. All right, moving on to part 2, bacterial and parasitic STIs. First up here is the protozoan parasite Trichomonas osmasis. For this one, just remember TRICK. It presents with T for thick, foamy, greenish-yellow discharge. R is for intense redness, which actually often gives the cervix a distinct strawberry-like appearance. I for itching, C for cramping, and K kind of sounds out how it hurts during intercourse and urination. The primary treatment here is an antiparasitic called metronidazole, also known as Flagyl. But listen, here is the absolute critical patient education piece. Patients must avoid alcohol for at least 72 hours after taking this medication, or they are going to suffer a violently nauseating reaction. Seriously, not even a single sip of wine. Next is chlamydia, which is caused by a gram-negative bacterium. The defining characteristic of chlamydia is perfectly captured by our SILENT mnemonic. S is because symptoms are often completely absent. I for increased painful urination. L for lower abdominal pain. E for excessive discharge, N for neonatal conjunctivitis for risk in newborns, and T for testicles swollen. This silent, stealthy nature is exactly why routine screening during the first prenatal visit and then again in the 3rd trimester is just absolutely vital. If an infected mother delivers vaginally, the baby can easily contract that neonatal eye infection or even pneumonia. Now, often occurring right alongside chlamydia is gonorrhea. This brings us to the CLAP mnemonic. That covers tender testicles, hurting to urinate, edema, conjunctivitis risk, lack of signs in women, abnormal discharge, and pelvic inflammatory disease if it's ignored. To combat the high risk of neonatal conjunctivitis and potential blindness from both chlamydia and gonorrhea, modern protocol dictates that newborns are given erythromycin eye ointment immediately after birth. It's a really powerful preventative measure. That brings us to part 3, the 4 stages of syphilis. So, syphilis presents a really fascinating but serious chronological danger. It begins in the primary stage with highly contagious but actually painless chancres. Then, weeks later, the secondary stage kicks in, bringing a full-body rash and flu-like symptoms. If left untreated, it enters a latent stage where symptoms completely vanish for years. But make no mistake, the bacteria is still there. Decades later, it can erupt into the tertiary stage, causing severe neurological damage, heart failure, and these destructive, soft, tumor-like growths called gummas.
And this timeline matters deeply for maternity care. Think about it. A pregnant patient in the latent phase has absolutely no visible symptoms, right? Yet the syphilis bacteria can seamlessly cross the placenta via the bloodstream and cause devastating congenital defects or even stillbirth. This is exactly why aggressive screening is the standard. And when it comes to treating a pregnant patient, penicillin G is literally the only safely recommended treatment to cure the infection and protect the fetus. Okay, let's jump to part 4, hepatitis B and the liver.
We all know the liver is basically the body's filtration engine. When it gets inflamed by hepatitis B, it starts to fail, which brings us to the HEPA-B mnemonic. H is for hepatomegaly, that's the enlargement of the liver. E for extreme fatigue. P for pale stools. A for abdominal pain, specifically localized in the right upper quadrant. And the hallmark is the B, total bilirubin buildup. When the liver can't process bilirubin from old red blood cells properly, it leaks into the skin and eyes, causing yellow jaundice, and spills into the urine, turning it dark. Because hepatitis B can be passed through the heavy exchange of bodily fluids during delivery, hospitals have an incredibly rigid defense protocol. If a mother is positive for hepatitis B, we can actually protect the newborn from lifelong liver damage. We do this by administering hepatitis B immunoglobulin within a strict 12-hour window after birth. That provides immediate passive immunity. And then this is followed seamlessly by a structured multi-dose vaccination series starting right at birth. So we've seen viruses attack localized mucosal tissues, and we've seen them target specific organs like the liver. But it begs the question, what happens when a pathogen's target isn't an organ, but your body's primary defense system itself?
Let's explore that in part 5, how HIV attacks the body.
Just to give you a sense of the global scope here, at the end of 2020, an estimated 37.7 million people were living with HIV globally. Decades of intense research have been poured into understanding exactly how this single virus operates. Here's how it works. HIV specifically hunts for white blood cells called helper T cells, which have a CD4 receptor. The virus attaches to this receptor and fuses with the cell. Once inside, HIV unpacks a sort of biological suitcase of enzymes. Because it's a retrovirus, it actually works backward, using reverse transcriptase to turn its own RNA into DNA. Then it uses integrase to physically insert that viral DNA directly into the host cell's command center, its nucleus. The cell is completely hijacked, forced to endlessly replicate and bud new mature HIV viruses until the host cell is entirely destroyed. Now, here's the thing. HIV rarely kills a patient directly. Instead, by systematically destroying those helper T cells, it bankrupts your immune memory bank. When a patient's CD4 count drops below 200, they officially progress to AIDS. At this point, opportunistic infections, we're talking rare cancers like Kaposi sarcoma, severe viruses like cytomegalovirus, or bacterial threats like tuberculosis, they can easily invade and overwhelm the defenseless body. Which brings us to our final section, part 6, managing and treating HIV. For prevention, we heavily rely on PrEP. Think of PrEP as a daily shield taken before exposure for high-risk individuals. But if an exposure actually happens, say a needle stick injury in a hospital, we use PEP. PEP acts more like an emergency fire extinguisher. It's a 28-day antiretroviral regimen that absolutely must be started within 72 hours. This just brilliantly demonstrates how we can pharmacologically block the virus from establishing a foothold and completing that complex life cycle we just looked at. For those who are already living with HIV, preventing opportunistic infections is a vital daily practice, and it's summarized nicely by the weak mnemonic. They must consume safe water, eat fully cooked foods, avoid risky activities, keep vaccinations current, limit exposure to animal feces, like from cats or birds, to avoid toxoplasmosis, and, most importantly, never, ever skip their antiretroviral therapy. These ART medications are amazing. They specifically target and break the links in the HIV replication cycle. And here is the truly incredible part. If an HIV-positive pregnant patient meticulously adheres to their prescribed ART regimen during pregnancy and childbirth, the risk of transmitting that virus to their baby drops to less than 1%. It is an absolute medical triumph that a retrovirus this complex, and honestly this devastating, can be biologically restrained to protect the next generation. It really leaves us to wonder, with continued advancements in virology and proactive maternal fetal care, what breathtaking medical breakthroughs are next?